to the right of the left of it.
So, good afternoon everyone. This is the third RPIW shout out that we've done for the organisation. It's the first in the particular value stream that's looking at outpatients. And back in Seattle, when we were deciding what our value streams were going to be, we wanted something around how patients access a bed better, because we thought that was a particular thing for the organisation, of how we could help patients. We wanted something around diarrhoea because we were challenged around how we look after patients with C. diff. And although there are only a small number of those patients each year, there's a vast number of patients with diarrhoea, and sorting out the patients who've got C. diff from all the other patients who've got diarrhoea is a challenge that we're facing and that we're under the spotlight for. We wanted three, and then we thought, well, the third naturally had to be outpatients, because however busy we think we are as an organisation, the real busyness is in outpatients. So 91,000 patients come to the ED each year, 350,000 patients come to outpatients. If we get complaints feature in the outpatients area of how long people have to wait, or what they discover when they arrive, or how easy it is to make follow-up appointments. So it's an important kind of shop window for us as an organisation. So that's why we chose it. I was the person blessed with the opportunity to sponsor the outpatient work stream. So I was very happy to work with the team around getting the outpatient RPIWs lined up. And I'm very pleased that the first one is in the booking office, and how we handle referrals when they come in, right through until the patients find out when their appointment's going to be. I've walked through the area a couple of times. I've walked the Gemba. Okay. I've seen 1,000 patient letters lined up in a pile. Okay. And I'm really excited to see what is the output of the work you've done in the context of how much energy there was on Wednesday, which was, I'll think about that energy for a long time. It's really good. I think you've met a little bit of kind of, can we really do this stuff? You know, this stuff that we, the experts, have come together and are designing. And the answer is yes, because it's a safe process, okay? We believe that you're describing something that we're going to look at 30 days and 60 days and 90 days and understand, has the benefit been realised? If it has, great, how do we take it further afield? If it hasn't, or if there's a knock-on effect on something else, then you and I together need to just understand that and understand what changes we need to make without throwing everything out with the bathwater. So with that introduction, I'm really grateful to you for giving so much time and so much energy, and now I'm going to sit back and watch you perform. All right? Thank you.
So my name's Alara, and I've been workshop lead for this rapid process improvement workshop. We've been looking, as Des said, at the ophthalmology process. So it's from booking of adult new appointments through until patients having a phone call to say that they've actually got their appointment and what that means along the way. We've worked with 10 people in the team this week, a fantastic group of people from people start from the outpatient booking office, medical secretary, consultant ophthalmologist, nurse from the outpatient department, Cerner and IT and information colleagues, 2 service managers, and I hope I haven't forgotten anybody. Shout if I have. We've also had an advisory team that really helped us this week, and they've included people from estates, Switchboard have helped us, Cerner have helped us, and medical records as well. I just wanted to draw your attention to this project form. So way back in March we had a sponsor development session where one of the suggestions that came up was to look at the booking process. And what you've got on the right hand side there are what we call Kaizen bursts, and they are all the ideas and suggestions of ways that we could improve the process, which we've addressed this week. I'm going to hand over to Helen, team leader.
Good afternoon, my name is Helen and I've been the team leader for this Rapid Process Improvement Workshop. So in preparation for this event, the team have spent time out on the Gemba, so that's the place where the work is done, observing the current state. So they've involved talking to all the people involved in the process, so the consultants, the booking clerks, the speciality booking staff, the nurses and the ophthalmology secretaries. This has enabled us to gain a greater understanding of what's currently happening. We've formulated a target progress report in which we've captured baseline metrics from which we could measure any improvements. Our sponsor Natasha has kindly set us challenges throughout the week based on these metrics. From the data collected, the TAC time for the process of booking an ophthalmology adult outpatient appointment is 17 minutes. So TAC time is the pace of customer demand. The outpatient booking office is open 9 to 5, so this is 480 minutes. According to the data we have, there are 28 adult ophthalmology referrals received a day. This means every 17 minutes a referral needs to be transformed into an appointment if customer demand is to be met. Examples of the other metrics on the target progress report include staff walking distance. So one of the ophthalmology booking clerks was walking 726 steps to deliver a referral back to the outpatient department. The work in progress, which is the number and the location of where the referrals are in the process for adult ophthalmology, is 1,331. That means there are 1,331 patients waiting for their referral to be transferred into an appointment. We also captured the number of duplicate referrals, which we had a baseline of 13%, and we captured information on patient experience.
Hello, my name is Linda. I'm the Outpatient Services Manager and co-process owner of the RPIW. The value stream map or timeline demonstrates our current process, which is full of duplication, non-value-add process steps or waste, and a lengthy patient journey from receipt of referral to appointment booking. All this results in non-standard work and poor patient appointment booking journey through the trust. Demand for the service is high, overbooking is the norm, but this is not captured correctly in trust clinic utilisation statistics. The impact of the current state sees additional work being undertaken by staff in the booking process, including a high volume of calls received from patients chasing appointments, delays in grading of referrals, and complexities in the referral process that add no value to the internal data and ultimately the patient. The room for improvement is huge and fully achievable, as you will hear from my colleagues.
Hello, I'm Dave. I'm from the outpatient booking office. I work at the point where the referrals are received from GPs or opticians. These have to be opened, date stamped, sorted, and a specialist allocated using a Bible we refer to, giving names of consultants for various specialities. These are then entered on the system and forwarded to the consultant for grading. At present, this involves taking referrals once a day to the nurse's room in outpatients. This involves a round trip of approximately 14 minutes, as you will see from the spaghetti chart showing the journey involved. Medical secretaries are also coming to our office during the day, so you'll see there's a duplication of work and effort. Consequently, we now introduce the system with the cooperation of the postroom staff for a once-a-day collection and delivery to the secretaries in Limpsfield Ward using a unique white bag courier system. This saves both us and the medical secretary's time.
Hello, my name's Kerry and I work in the Outpatients Bookings Office. One of our problems has been with the multifunctional printer and fax machine, which is located on the above floor of the referral team. Many people use this, resulting in the faxes being mixed up. This needs to be collated and occasionally pages get lost. Steve Allen in Estates has arranged for a fax line to be introduced and the fax machine moved downstairs to be in the same office with the referral team.
After discussions with various departments, we've realised that some of the information we've been adding to the system is unnecessary. Consequently, we do not now input these details, which, while saving seconds per referral, this mounts up with the number of referrals we put on each day.
Hi, my name's Julie Roberts. I'm part of the medical secretarial team based on Limpsfield Ward. As part of the process, the referral trays in outpatients department has now been removed and the referrals are transported directly from OBO via the post room to Limpsfield Ward, where they are prepared with the triage form for grading, last letter if appropriate, cutting out any opportunity for delay. The term for this is set-up reduction. A rota has been devised for secretaries to join consultants in clinic on a daily basis but for protected admin time to grade those referrals. A draft standard work process was created for this and streamlined with my medical secretary colleagues on Limpsfield using PDSA, as we've learnt this week, as plan, do, study and act.
My name is Luke Herbert. I'm a consultant eye surgeon. My colleagues and I read referral letters and we try to decide how quickly patients should be seen and who should see them. This changes the way the patient's managed in about 2 in 5 letters, so it's an important step. To do this effectively, I have to check old letters, clinic attendances and sometimes the notes. In the old state, I would have to look these up myself on the computer or request the notes, introducing delay. In the future state, this information will be prepared beforehand. We also redesigned our triage form using PDSA and worked things out together so that we could make the specialty booker's life much easier by being clear, avoiding scribbles. It sounds very simple and very obvious, but it's new. We all spend a lot of time answering queries about appointments, often because they haven't been sent or because we weren't booking beyond 6 weeks in our clinics to avoid us having to move clinics around. We repeatedly asked why we can't book beyond 6 weeks, until our operations director said we could use all available clinic slots and put in fire breaks. Fire breaks are clinics left open at regular intervals so we can accommodate any patients that have to be moved. We're going to monitor this very carefully, and if it doesn't work, we will try something different. Finally, we found that the way that we counted empty clinic spaces meant we thought there were lots more spaces available than there really were. Just looking at one clinic, the one that's up there, showed that there were empty slots, that's the open circles on the diagram, but you can see many more booked over the clinic template, which is marked in brown. We also heard earlier that 13% of our letters were duplicate. That meant 13% of the work we were all doing on these letters was entirely wasted. Now, one of my colleagues in the booking office discovered things are actually even worse than that. We're putting that right too.
My name's Amanda. I work in the outpatient booking office. One of our tasks this week was to look at ways of reducing the duplication of referrals. Current statistics show that 1 in 4, so 25% of referrals are duplicates. We have discovered this week that an encounter on Cerner was removed in the January update. This encounter enabled us to see future appointments that were already booked. This facility has now been reinstated by Adrian Compton across all specialties, and this will greatly help with the reduction of duplicate referrals.
During the week, we undertook an exercise to build a paper aeroplane. Initially, we built it in a chaotic manner, resulting in few aeroplanes actually being completed. We changed and simplified the process, concentrating on one particular task per person and completed many more aeroplanes as a result. To take this forward, we then surveyed the booking office staff to try and apply the same principles in terms of our work. Whilst most of the staff came back as a negative, they did not want to take this forward, we will be applying the same concept in the outpatient ophthalmology booking team. We also looked at the ophthalmology letter, which had inconsistent large font size and a PALS number for patients to contact, which resulted in calls to them. Both of these items have now been resolved and the PALS number has been removed. The letters also had a leaflet attached. Much of the information in the patient letter is also contained in the leaflet. So the letter has actually been changed to include any outstanding items and therefore reducing the paper sent to the patient. Numerous calls are received into the booking office not relating to outpatient appointments. We've worked with Switchboard this week and Sarah Reeve and her team to change the message given to patients if they call into Switchboard to include the word outpatient with the appointment option.
Hi, I'm Victoria Phillips and I'm a senior analyst. During this week we had Cerner come in and meet the team, and during that time we were able to discuss some of the functionality within the system as well as what may be coming up in the future. We also had some of our questions answered. This also gave us the opportunity to give feedback to Cerner for ideas for the future as well. Having this time with Cerner, we've been able to dispel some of the negative myths about the system.
Hi, I'm Jackie. I'm one of the Cerner trainers. One of the things we quickly identified was that the recommended Cerner process for overbooking a clinic was not being followed, which is historical. For some, this was a real light bulb moment. Additional slots are being added to the clinic template instead of an overbooking process being followed. Added slots are not easily identifiable to the clinic template. We tried the correct recommended workflow to do this. We chose one of Mr. Herbert's future clinics, which currently looks like this. The clinic template should be a total of 18 slots, and there are 31 patients booked. This is 13 additional slots, which are not easily visible. We removed the additional slots, rescheduled the patients following the overbooking process. The overbooked slots are grey with a black border and clearly visible now. There are still 31 patients in this clinic. There will be a plan put in place to roll out the relevant training to all involved in this process.
Good afternoon, I'm Tobias. I'm the Service Manager for Ophthalmology and the Co-Process Owner. As you have seen from the current value stream map, there are many Kaizen clouds, opportunities that the team have worked on resolving. So the future state value stream map shows a substantial reduction in waste and an improvement in the process time from receipt of referral to the appointment being booked. The original value stream took around 80 days from receipt of referral of a routine referral to the appointment being booked, and the new value stream aims to deliver 80% of those referrals from moment of receipt to appointment being booked down to just 5 days. This will have a number of benefits. Patients will receive an appointment within 5 days of referral, reduction in the amount of patients phoning to find out about their appointment, freeing up the booking staff to get on with what they need to be doing, reduction in the amount of duplicated referrals, freeing up both consultants and admin staff. We've also overcome some myths about Cerner's functionality, providing a lot more control over clinic management. This will provide a reduction in the amount of overbooked slots, an improvement in patient experience, clinicians having more time to see patients as a result of the reduction in overbooking, and more accurate data in order to plan for the future. Thank you.
So this week we've managed to test and pass a number of referrals through the newly designed process. From it we've identified that it is possible to get referrals from point of receipt by OBO to an appointment being booked within 5 days. This is a 94% reduction in the length of time it takes to book an appointment. There's also been a 100% reduction in the walking distances that OBO clerks have been doing and the consultant. The OBO office has also undergone a 5S improvement and it's now reached level 2.
This RPIW has identified many opportunities for improvement. These opportunities will be implemented and tracked through the newspaper and reported on over the next 30, 60 and 90 days. The different sponsor challenges and the plan do study act cycles we will be working on will also be tracked through the newspaper, and we will feed back to the different home teams, value stream sponsors and the KPO.
There have been many learnings from this RPIW which we now know can be implemented and rolled out to other specialties, and we will be working with other areas to ensure that what we have done this week is embedded in our processes. Thanks.
So, for the week, we've had brilliant enthusiasm from the team and great collaboration from the wider trust and colleagues in Surrey as well. We've had many light bulb moments that all have implications, not just for this work, but more widely across the trust. Our lessons learned include a small change can have a huge impact for patients and for staff. We want to be in a state where we have no more letters about letters, no more phone calls about letters. And during what we've done this week is we've learned how to unwobble the wobbles. Please take time at the end of this session to have a look round at the work that's on the walls, especially our value stream state and our future state over there, and to talk to the team. We haven't been able to do this on our own this week. We've had a whole host of people that have helped us, and there's just some of the names up there. And now we have a word from Natasha, our sponsor.
Dying to get away, so I'm not going to repeat anything that's already been said. So I just wanted to say a real thank you to the team. They've worked really, really hard. I know they're extremely tired. It's probably much more tiring than being at work in your normal workplace. A special thank you to a couple of the young ladies that have spoken today that I know are really terrified of coming up here and talking to you. So they deserve an extra special thank you. And yes, I hope you do have a look and see what the team have achieved. It might seem like that, you know, what we've done, what the team have done was obvious and nothing terribly clever, but actually it's not what we used to do, and we never had the time to step back and think about how we do things differently. So I think it's well deserved, and I'd like everybody to...
My name is Rhonda Stewart. I'm the Transformation Sensei from Virginia Mason Institute in Seattle, Washington. I just want to mention how did we apply SASH Plus today? Right? So I know that we moved equipment and we changed systems and tools, or we're going to in the future. We have a plan. We level loaded the work among operators, and really what that means is that the right people are doing the right work, that we're delivering the work to the next operator in the right format. We learned that with the airplane. We're not moving those defects along in the process, and we're aligning the skills with the task, and so using that postman to do deliveries, things like that. We have a plan for the work in process and that big stack of backlog, right? And so we're going to meet with the process owners after this and really come up with what is that plan? What does 30 days look like? What does 60 days look like? I have every confidence that the process owners are going to get the plan done and readjust when needed. And they're going to work with the team to make sure that all the needs are met, and if things aren't working, they're going to listen. All right? The next thing I want to do is I want Sue to come up here. So Sue is now certified in the Virginia Mason Production System, aka SASH Plus. So congratulations. Sue is the first of many, and Alana will be next. All right, and you're going to hear a closing comments from Des.
Firstly, I just wanted to ask, how many people is it the first time you've been in this lecture theatre? So, well, welcome to the lecture theatre. We used to do quite a few of our meetings in here, kind of senior team meetings and all staff meetings, and kind of moved them out into the glassy, airy area out there. But come, because they're all kind of like this. They're always just telling you what's going on, what's new. They're generally full of enthusiasm, because usually Michael doesn't. So, you know, just come along. If you see them advertised, come along. I'd just like to add my thanks, really, you know, to do something new, to come out of what you do every day, to put yourself forward and take something on for the good of the trust and for the good of patients, and that is very brave. You know, I couldn't tell which of you it was. I knew that there was someone who didn't want to stand up and talk, and I didn't know who it was, and I couldn't tell who it was. So, you know, fantastic. So well done for overcoming that as well. Be very proud of what you've achieved together. It was really energising on Wednesday when I came around, and I thought I might have to drop in for 5 minutes, you know, say hello a little bit. It was really fun to stay and hear what you've done. So thank you very much, and go back, take on all the learning, and put your hand up for the next thing to improve things. Okay? Thank you.